obviously as a working clinician, you have success stories. Can you give us a brief outline on one of the cases that you've treated with great satisfaction?
This is one that actually has just been accepted by the American Journal of Medicine. Let's call this person Katie, and it's Katie's story. And what we decided to do, we approached the journal and they were very excited about it, is I wrote my story of her and she wrote her story of me. And they'll be published concurrently in the journal. Katie came to me, the nature of my practice, because of my work, is to see patients with difficult to diagnose and manage functional GI conditions or GI conditions in general. It includes inflammatory bowel disease. And the patients are referred, half of them are from out of state or out of the country. So I was referred this patient through a program, a national program that selects the doctors to match the patients. And this patient had been to the Mayo Clinic, the Cleveland Clinic, to many doctors, was very dissatisfied, was doing very poorly. Now her symptoms, this was in summer of 2015, were, from a medical standpoint, irritable bowel syndrome with diarrhea and functional dyspepsia, which meant that she had abdominal pain and cramps with diarrhea, and she had early satiety, or when she ate, she'd feel full very quickly, and that would make her feel uncomfortable. Now, this is critical because her story began that she was having these symptoms, and in addition to that, in her early 20s, she developed type 1 diabetes. That diabetes got controlled, but she began to think that in order to control her symptoms, that her diabetes must be controlled as well. And she became over-involved in controlling her food. She became what you would call orthorexic. She became fearful of eating everything, sugary foods, gluten, high fats. And she lost 30 pounds. And in the process of this, she became so obsessed with the symptoms that she would check her blood sugar 10 times a day, constantly. Now, this got made worse, getting into the doctor-patient communication, because she went to a doctor and the doctor said, there's nothing wrong with you. She went to another doctor and said, well, you have a little bit high sugar. This is before the diabetes. Just watch your diet. Another one said, you just have to learn to relax. She went to another gastroenterologist who said, who did a gastric emptying study and said, oh, you have gastroparesis. In fact, she had some delayed emptying, but it was not clinically meaningful. And she said, gastroparesis. And the doctor said, you've got the stomach like an 80-year-old. This was to be reassuring.
Yeah.
The doctor said that, and she said, my God, I'm 20 years old. What am I going to be like when I'm 80? That led her into this vicious cycle because every time she ate, what she really had was dyspepsia, which was different than gastroparesis. And she felt that she had to control what she ate. Well, as a result of this, she lost the weight. She became really orthorexic. She wouldn't eat. She was anxious, depressed, stopped working. She was a special education teacher, went at home, stayed in bed all the time. She came to see us. And I think what we did that was different was, first, as I mentioned earlier, we legitimized that these symptoms are real. She has irritable bowel syndrome. She has dyspepsia. Here are the criteria. This is what you had. Very reassuring to her to have that. In addition, we said, now we can work on this together. And in her story, she said, we can work on this together. No doctor has ever said that. It offloaded the sense of responsibility that she felt on herself. Her self-esteem was plummeting. She felt like a failure. She couldn't control her symptoms. Doctors were not really helping her. So we gave her the opportunity to really help manage with myself as a cheerleader, so to speak. In addition to that, we used the right medications. We put her on buspirone, which helps the stomach relax properly. We put her on an antidepressant, an SNRI agent called duloxetine, which helped with the pain regulation. We put her on rifaximin, which was an antibiotic that helps the dysbiosis. So we did all the proper treatments. And we sent her to a psychologist to do cognitive behavioral therapy. Within 5 months, she had gained back the 30 pounds, went back to work, had a sense of control over her illness, and that's the story. Now, what did we do? We legitimized the condition, we provide the proper treatment, we gave her the proper diagnosis, and in the end, she took control and felt back where she was before.
Yeah. Which ideally should happen at every consultation, but obviously doesn't.
You have to do the proper diagnosis, proper understanding of the condition, explaining it to the patient, and then providing the proper medication, and in a way that's communicated properly.
I think that's a good place to end it. Thank you very much for
Okay.
your profound wisdom today. Thank you.
Thanks very much.